March is National Colon Cancer Awareness Month. Excluding skin cancers, colorectal cancer is the third most common cancer diagnosed in both men and women in the U.S. Many colorectal cancers can be prevented through regular screening. Here to discuss the importance of getting screened is Dr. Marc Saunders, a board-certified general surgeon with Baptist Medical Group. Dr. Saunders, thank you so much for coming on today.
Thanks for having me.
To get started, share with us a little about yourself and your experience as a surgeon.
Oh, well, I grew up in New York, and I went to college and medical school out there, and then I moved to Cleveland, and I did a rotating internship. Then I moved to Youngstown, Ohio, where I did my general surgery residency, and I practiced there for 22 years. And my wife and I just moved down to Pensacola, and we're thrilled to be here. And I'm especially thrilled to be able to take care of the people in this town. It's a beautiful town.
Great, great. And speaking of that, what goes into a colorectal screening?
Well, colorectal cancer screening, the gold standard is colonoscopy. And it starts at age 50 with the first screening test in a patient who's at average risk. Average risk patients are people who don't have any family history of colon cancer. If you do have a family history of colon cancer in a first-degree relative, then that puts you at a higher risk. After that, the colon cancer screenings are usually every 10 years for the average risk patient. But there are a few different types of diseases or illnesses or hereditary things that might increase the risk. So if, for example, a patient has Crohn's disease or ulcerative colitis, that increases their risk of colon cancer in the future. If a person is from a family who has a hereditary polyp syndrome, then that increases the risk. And that would increase the interval, or would actually increase the frequency of colonoscopy in the future. Also, if a first-degree relative had colon cancer, then the person who's going for the screening should have their first screening either at age 50 or 10 years before the age of diagnosis of that first-degree relative. So, for example, if your father had colon cancer at age 52, your first colon cancer screening should be at age 42.
Okay. What are some warning signs or symptoms of colon cancer that we should be on the lookout for?
Well, unfortunately, colon cancer, like most cancers, can have no symptoms, to start. It's not until the cancer becomes more advanced that we start to see symptoms. If it is advanced, things to worry about are things like changes in bowel habits, alternating constipation and diarrhea, rectal bleeding, obviously, unexplained weight loss, decreased caliber of the stool, abdominal pain that is new onset. All those things should be evaluated.
Once the cancer is identified, what is the treatment process like?
Okay, well, first thing we have to do is figure out whether or not the cancer has spread. Okay. That changes the treatment from that point on. Assuming the cancer has not spread, then the treatment usually starts for most colon cancers with surgery. Then we take that specimen, the pathologist looks at it, stages the tumor to see whether or not it has spread to the lymph nodes, whatever, and to see whether or not chemotherapy is warranted. If it's an advanced tumor, then it changes the treatment completely. For rectal cancers, recent studies have shown that starting with chemotherapy before surgery usually increases the chance of a better long-term outcome.
Okay. And what are the chances of that cancer returning once it's been treated?
Well, I mean, it all depends upon what stage it was at when it was diagnosed, whether or not it had spread, what treatment the patient got in the beginning, for the first round, the age of the patient, the genetics of the tumor. There's several factors that are involved.
I imagine after the treatment concludes, there's going to be some follow-up screenings for the patient. So
colonoscopy should be done, again, for the average risk patient every 10 years. There are other alternatives, but the gold standard is colonoscopy. Other things that can be done in place of a colonoscopy every 10 years are every 5 years a patient can have a flexible sigmoidoscopy, which is a shorter scope. It sees about a third of the colon, coupled with what's called an air contrast or a double contrast barium enema. My feeling is if you're going to have to clean out your colon and have a short scope put in there, you might as well have the long scope put in there and get the proper test done and see everything.
Right.
There are also some other studies that we do, some in the office, one is called fecal immunochemical testing. One of them is occult blood testing. One of them is fecal DNA testing. The first two, the occult blood testing and the fecal immunochemical testing, those are done yearly. But any positive there, and we have a very low threshold for positive, warrants a colonoscopy. And the same thing goes for the DNA testing. That's every 3 years. But again, any positive study, you need a colonoscopy. Might as well just get the colonoscopy.
Might as well. Let's say someone just has some questions about the screening process or about the treatment process. Where would they go to get those questions answered?
First thing you do is you go to your primary care doctor, or your primary care provider. Let me just preface that by saying the whole point of colon cancer screening is to not let it get to the colon cancer stage.
Right.
So colon cancer starts as benign little growths called polyps. And these polyps, there's a wide range of different kinds of polyps. Some of them have no malignant potential at all. Some of them have a small amount of malignant potential, and some have a lot of malignant potential. So what we try to do is we try to get those polyps out before they turn into cancer. If you plant a seed and then say, I don't want that little sapling there, and you dig it up, it can't grow. It's the same kind of thing with a polyp. So best thing to do off the bat is to talk to the primary care provider. The primary care provider then knows all the doctors in town, all the specialists in town. Most of the time it's either a gastroenterologist or a surgeon that does colonoscopies. I myself do colonoscopies. I've been doing it for years. And they'll get the patient referred. In the absence of a primary care provider, or if somebody wants to bypass the whole screening, Baptist Hospital has come up with something called the Open Access Colorectal Cancer Screening Program for Digestive Health. And what that involves is your primary care physician calling or referring you to the open access program, where a nurse navigator will ask questions of the patient over the phone to screen whether or not the patient has any risk factors that would prevent them from having a colonoscopy. Most people are accepted into the program because colonoscopy is a very well-tolerated procedure in pretty much all the age groups. So once that's done, all the questions are pretty much asked over the phone. The patient will get instructions on how to prepare the colon, because there is a colon cleansing, and that's probably the worst part of the whole thing. They do that at home. They come in the morning of the procedure. They meet the physician that's doing the procedure. They have it done. They get put to sleep. They have it done. They wake up. They go home, and then all of the information is forwarded to the primary care provider.
Fantastic. And at that point, you would make a decision based on the results.
Right.
Obviously.
Right.
Awesome. Well, thank you so much for coming by.